Evening, everyone, and welcome to our webinar. Hope everybody is doing well and keeping safe. Today, I'm going to chat a bit with you about one facet of infertility, mainly male infertility. So if we look at the rate of infertility, how often we encounter couples with infertility, we find that out of every 6 or 7 couples attempting a pregnancy, one couple will need some help. They may have some cause that's preventing them from getting pregnant. And when we do the workup to see why a couple is not conceiving, and around 40% or so of the time, we may find a main factor. Sometimes it's the only factor, sometimes it's a combined male and female, and sometimes that's why we don't find any reason called unexplained. Today, we're going to focus on the male factor as a cause of infertility. So when we evaluate a couple for infertility, part of the workup is going to involve us doing a semen analysis. And the semen analysis would uncover any male factor as a cause for infertility. So when we do a semen analysis, we're looking at few factors on the test. We're looking at, first off, is the volume of the semen adequate or not? So over the years, the norms or the cutoffs for normal for a semen analysis have changed. And the latest revision by the WHO around 2010 shows that if you had a volume of 1.5 ml or more, it's normal. If the sperm concentration is at 15 million sperms per ml or more, that's normal. If the motility is around 40% and if the shape is around 4% normal, that is normal. Now we look at the sperm shape, we're looking at multiple parameters. We're looking here at the sperm head, the sperm middle piece, and the tail. Sometimes the heads are large, sometimes they're thin and tapered, sometimes you have double heads, double tails, and multiple other things that we look at. Typically, sperm that are abnormally shaped do not fertilize the eggs, while normal shaped sperms would fertilize the egg. If we take a look at the process of sperm production, the sperm production, so I'm trying to get my cursor on. Sperm production starts in the testicle, and it starts under the effect from a stimulus that comes from the brain. The brain produces a hormone called FSH that goes to the in a man's body to the testicles and would end up ordering the testicle to start the sperm production. The sperm production also needs the hormone testosterone that's also produced in a testicle to be produced. And once it is produced, it will enhance the sperm production. The sperm production takes around 3 months to be completed. The last 10 to 12 days of the sperm production, the sperm is spent in the area above the testicle called the epididymis, where it matures and achieves its motility. Then, I'm sorry, I'm trying hard to get this cursor to work. Let me see how I can get it to work. Here we go. So the testicle is where the sperms are produced under the effect of the hormones coming from the brain. And the sperm is produced, then it moves to the epididymis, where it matures and attains motility. And then it leaves the epididymis through a structure called the vas deferens. It's stored in the seminal vesicle, and then when ejaculation happens, it goes through the prostate, through the urethra, out from the man's body. So when we look at causes of low sperm production, we're going to be looking at all those structures and at the brain signal as well. So when we were working with a couple for infertility, on both the male and the female side, the first thing we do is we get history. Because many a time from the history you can tell there's probably a reason for infertility. And typically, if we uncovered a male factor, we're going to ask the male whether he had any history of testicular trauma or undescended testes. All could lead to decreased sperm production. whether there is any family history of infertility due to male factor, especially in siblings or in the father. We'll also ask about history of any surgeries, whether they had any hernias. Sometimes during a hernia surgery, inadvertently, they may cut or interrupt the vas difference. And then we do a physical exam. And on a physical exam, we're going to look at the size and consistency of the testicle. We're just looking for some structures behind the testicle that we refer to as varicose veins. Also, we're going to look at the presence or absence of the vas difference. And ultrasound can also help us differentiate whether there's any varicocele or not. And then we do some blood work to look at the hormones, look at whether the testosterone is low or not, and whether the brain signal is there or not. So if the brain is not producing much hormone to drive sperm production, we learn that it's probably a hormonal issue that we can improve on. But if we see that the brain hormones are too high, but the testicles are not functioning, then we suspect there's a testicular problem that we're dealing with. And sometimes we would look at the genetics of the man. In severe cases of low sperm count or absent sperm count, then we would look at the karyotype and at the Y chromosome in particular. There are certain tests to look at certain regions, whether there's any deletions or absence of part of the chromosome. When it comes to treatment, it's pretty much gonna depend on the underlying factor. So sometimes if we find that the brain is not producing enough signal for the testicles to produce sperm, we can use certain medications to either improve the brain signal or replace it by giving the FSH hormone to the man to produce the sperm. We should also enhance testicular testosterone production. As you know, if a man is using testosterone replacement, that this would actually slow down or stop totally the sperm production. So if we learn that's the case, we're going to stop testosterone use and wait a while to see whether testicular function is recovered. Sometimes we will need surgery. If the vas difference, for a reason, we find there's an obstruction, then we can try to fix it. Or if we find, let's say there's a large varicocele that's affecting sperm production, it could be taken out. And sometimes we need surgery to extract sperm from the testicles to use them if there is no sperm in the ejaculate. Behavioral modifications could be if the person is exposed to environmental factors like smoking. If a man is a heavy smoker, we'll advise them to slow down or stop smoking because this will improve sperm function. Other behavioral modification could be avoiding soaking in hot tubs or saunas, avoiding wearing tight underwears, and what have you. And then we will look at fertility treatment. When we talk about fertility treatment here, we're treating the couple, the man and the woman. And if it's a sperm, a low sperm condition, like a male factor, we may want to look at certain treatments that would enhance the sperm function or would improve on the fertilization of the egg. So in certain situations where the sperm numbers are low, but not significantly low, we still have a good number of moving sperm, but not necessarily normal, we may consider a process called insemination or IUI, where we would either time the insemination with the ovulation of the spouse or the partner, or we can induce ovulation in the spouse and the partner by using certain ovulation inducing medication that we will time ovulation and then we'll take the sperm from a sample from the man, we wash it, i.e. we prepare it for insemination and put it inside the woman's uterus right around the time of insemination. And this could help in the sperm function and may achieve a pregnancy. Now, the sperm numbers are too low, or there's low motile sperm number, or if this has been done several times and it's not working, then we can look at other treatment options like in vitro fertilization or IVF. When we do IVF, the goal here is to stimulate the ovaries to produce several eggs at the same time. So when we look at the ovary before stimulation and we give the woman the hormones that will make their ovary produce several eggs at the same time. This is monitored, and as we monitor it, we would reach a certain size, we say it's ready to get the eggs out. We'll do a procedure under anesthesia. We'll do a vaginal ultrasound guided egg retrieval. We'll put a needle through the vaginal wall into the ovaries to aspirate the eggs, and then the embryologist would be isolating eggs as we do that. And then in male infertility, we would resort to a process where we would inject one sperm in each egg. And here's a video clip from our lab doing a process called intracytoplasmic sperm injection, or ICSI. Here we see the egg, and there's the microneedle with the sperm inside it. Sorry, let me see if I can get it to work. All right, let's see. I apologize for this difficulty here. Just bear with me for a second, I'm sorry. I promise you it works. Just let's see what we can do to make it work. Okay. So if I describe it to you, we basically take one sperm and inject it into each egg. To induce fertilization, and we would then grow the embryos in culture until the embryo reaches the implantation stage, going through the days of culture, and then we would be transferring embryo to the uterus of the spouse or the female partner to achieve pregnancy. The embryo transfer process is relatively simple. It's like a pap smear. We do it when the woman is awake. Without any anesthesia, it's very tolerable. And then we would wait for the result in a couple of weeks. If pregnancy is achieved, we support it for the first 3 months, and then the woman would continue with her OB/GYN like any other pregnant woman. Let's give these videos one last shot to see if we can. Oh, there. Unfortunately, not running today. I'm sorry about that. Sometimes we elect to test these embryos for their genetic content or for other genetic problems. If the couple is known to carry any genetic problem, and this is a process called pre-implantation genetic testing, where we get the embryo and we take few cells from the embryo to look at them in a certain way to count their chromosomes or look for certain gene mutations that are known to be carried by the partner or the patient.